Welcome to this video on CCs and MCCs, where we explore how to ensure your clinical diagnoses are accurately captured for coding. The key theme for this series is simple. For a condition to be correctly coded, it must be documented the right way, in the right place, your assessment and plan. Let's start with the most important rule. Your diagnoses belong in the assessment and plan. If a condition is buried elsewhere in the chart, like in a narrative or a flow sheet, it may not be picked up by the coder. Always place your diagnoses in the assessment and plan to ensure they are captured. Every codable diagnosis relies on a simple formula of three things. First, the documented condition. Second, the clinical support, such as labs, imaging, or exams. And third, the treatment or management plan. Missing any of these puts the condition at risk or may lead to a query. Requirement 1 is to document the condition directly. Use specific codable diagnoses like acute HFrEF or acute kidney injury. Avoid simply describing signs, such as elevated BNP or blood in the lung, as these are findings, not diagnoses, and will likely trigger query. Requirement 2 is to show the clinical support for your diagnosis. This includes relevant labs, imaging, culture results, physical exam findings, or the patient's past medical history. You will be queried if you omit these findings or if the documented findings are inconsistent with the diagnosis without further clarification. Requirement 3 is to clearly show the treatment or management. Whether you are continuing current medications, following up as an outpatient, or consulting a specialist, you must document your actions. A diagnosis without a documented plan is a red flag that puts the condition at risk of not being captured. Let's put it all together. When you document the condition, provide the supporting clinical evidence, and clearly state your management plan, you ensure the diagnosis is captured. For example, documenting, quote, acute on chronic HFrEF, along with BNP levels, echo results, and a cardiology consult fulfills all three requirements. There are 4 types of CCs, each with different documentation needs. These include clinical findings supported by labs or imaging, provider-assigned diagnoses, verified facts or patient-reported conditions, and conditions noted in the past medical history. Knowing the type helps you determine the required support. Keep these common MCCs on your watch list. They range from chronic conditions in your patient's history to specific clinical findings and diagnostic conditions like sepsis or acute respiratory failure. When you encounter these in your practice, ensure you document the full 3-part formula we discussed earlier. Be aware of these common CCs as well, which are also categorized by their source, such as PMHX or diagnostic findings. Remember that depending on the principal diagnosis for a patient encounter, some of these conditions may lose their CC status, so always remain vigilant in your documentation. In summary, make every CC and MCC count by following 4 habits. Put the diagnosis in the assessment and plan, name the actual condition clearly, show the supporting clinical evidence, and document your specific management plan. Using this approach helps ensure your documentation is complete and accurate.